So we are switching to a more surgical type of talk. Again, nothing to disclose. Magnetic sphincter augmentation is an effective treatment for reflux disease. It's a technically straightforward, highly reproducible, and is an outpatient procedure. In the earlier studies, patients with a large hiatal hernia greater than 3 centimeters were excluded for implantation of the device. This was primarily based on the FDA recommendation that considered its use as a precautionary in this context. However, research studies have encouraged the use of this device in patients with a large hernia. There are 2 studies has nicely set up the stage for other investigations, and that's why we started this project to address the need for objective follow-up data, direct comparison to those with no or a small hernia, and also including the patient with paraesophageal hernia. So we designed the current study with the following goals. First, to compare the outcome of MSA across the spectrum of hiatal hernia, and to evaluate the recurrence rate and pattern of recurrence after MSA. This was done to establish a classification system for hiatal hernia recurrence and to propose a management strategy. This is a retrospective review of prospectively collected data in symptomatic patients who underwent magnetic sphincter augmentation at our institution in a 4-year period. All patients completed a detailed clinical evaluation, including validated reflux questionnaire and objective Foregut evaluation consisted of EGD, high-resolution impedance manometry, pH monitoring, and video esophagram. Surgery is done laparoscopically and consisted of posterior mediastinal esophageal mobilization to achieve adequate intra-abdominal esophageal length, posterior crural closure with interrupted sutures, and placement of the links at the GE junction. Patients were then followed according to our follow-up protocol, and at 1-year follow-up, they were approached for objective Foregut testing. Here you can see the number of the patients who completed each of these tests. Before moving to the results, I would like to emphasize on some definition used in this study. Recurrence of hernia was determined based on the endoscopy done at 1 year following surgery, or if the patient presented with suggestive symptoms prior to that time. Post-operative dysphagia was defined as dysphagia score of 3 or greater on the difficulty swallowing item of RSI 8 weeks or later after magnetic sphincter augmentation, and clinical improvement was defined at least 50% improvement in the total GERD HRQL score compared to the baseline pre-op data of the patient while on anti-secretory therapy. The final study population consisted of 350 patients. 60% of them were female, 81.4% had hiatal hernia, and in this table you can see the distribution of the hernia across the groups. Of note, 22 patients had paraesophageal hernia in this cohort. We achieved excellent subjective and objective outcome measures at our 1 year follow-up, almost identical to the reported result from other institutions that they are doing magnetic sphincter augmentation. The rate of satisfaction, clinical improvements, PPI freedom, and normalization of acid was almost similar in all groups. MSA is a safe procedure. 92.3% of the patients were discharged home on the same day, and of the one that required at least 1 night stay, there was an increase in the need as we were moving towards patients with larger hiatal hernia. Same trend existed in the readmission within 90 days that reflects the more advanced age and presence of other comorbidity in patients with paraesophageal hernia. The overall complication rate was also increasing in a stepwise fashion by moving towards patients with a higher and larger hernias. We had 2 major complications in this cohort, and the rest were minor complications. Rate of postoperative dysphagia, need for endoscopic dilation, and device removal was also similar between the groups. The rate of hiatal hernia recurrence or upper endoscopy was 10% in all groups combined. This rate increased in a stepwise fashion by moving towards patients with a larger hernia. Of note, only 2.9% of the cohort were symptomatic and required reoperation within 1 year follow-up period. The factors associated with recurrence of hernia were increase in BMI after MSA, conditions that would increase intra-abdominal pressure, and minimal dissection approach to MSA. Based on our clinical experience and reoperation of these patients, we proposed a classification system for recurrence of the hiatal hernia after links. Basically, the type 1 are the sliding herniation, and the difference of the three subtypes is the relation of links compared to the GE junction. In type 1A, the links is at GE junction, and these patients only need repair of their hernia. In type 1B, the links is located too proximal to the GE junction. This is likely from inappropriate placement at the index surgery. If this is observed at the early postoperative period, our recommendation is to a short course of steroid and endoscopic dilation. And if we are facing with a large hernia, then we rather go directly to the hiatal hernia repair and replacement of the links. Here is an example of type 1 recurrence that the links has moved proximally. We see a small hernia. Patient symptoms improved with dilation and a short course of steroid. In type 1C, the links is located in the proximal stomach or cardia, and the management of this group depends on the status of manometry. In the pre-op high-resolution manometry, they would need either a repair of hernia or addition of a fundoplication or replacement of leaks if they have a defective valve. And type 2 and 3 are basically the paraesophageal reherniation, with the difference that type 2 has intra-abdominal location of the links, and type 3 is the herniation of the links into the thoracic cavity. In both of them, if the links is in an appropriate position at the GE junction, we just repair the hernia, and if it's not in the appropriate position, they would need also a anti-reflux procedure. This is a graphic image of a type 3 in which the herniation happened, the paraesophageal herniation happened. So in conclusion, the favorable clinical and objective outcome after MSA is independent of the presence or size of the hernia. Overall rate of the hernia recurrence on upper endoscopy was 10%, but symptomatic recurrence requiring surgery was only 2.9%. Patients with a large hernia or paraesophageal hernia have a higher rate of asymptomatic recurrence. The rate of complications, length of hospital stay, and 90-day readmission rates are higher in patients with large hernia or paraesophageal hernia. The rate of post-op endoscopic intervention, device removal, or reoperation for recurrent hiatal hernia are similar across the spectrum of hiatal hernia, and the minimal dissection approach to MSA should be abandoned. Thank you.